Remember that all of the technical information in this PowerPoint comes from the Diagnostic and Statistical Manual of Mental Disorder as published by the American Psychiatric Association, and I have added my own commentary as it relates to this course. Something to keep in mind as I go through this PowerPoint is that the DSM is a categorical way to look at mental health issues. It is included here so that if and when a client or patient comes into your office or clinic or practice and states they have been given a diagnosis, you have at least a rudimentary idea of what they mean. I am on the side of depathologizing and destigmatizing mental health issues, and I encourage all of you to seek to find out what may be driving the behavior that has been categorized or compartmentalized into a set of criteria. Expressed behavior that fits a diagnosis can be looked at as an adaptation to experiences or life events that may have felt overwhelming, chaotic, and sometimes even life-threatening. To learn about these definitions, diagnosis, and criteria is important, but always, always keep it in the forefront of your mind that you are in a working relationship with a person that may have had to learn ways to cope in less than ideal circumstances. And I ask that above all, that you stay curious about the person, not the condition. This PowerPoint is about schizophrenia and other psychiatric disorders. Schizophrenia this is part of a group of disorders as defined by abnormalities in one or more of the following 5 domains: delusions, hallucinations, disorganized thinking as displayed in speech, grossly disorganized or abnormal motor behavior, and negative symptoms. These are common features across all disorders in this classification, so I will define a few things first, then lay out specific aspects of each disorder. So delusions are defined as fixed beliefs that are not amenable to change in the light of conflicting evidence. Hallucinations are perception-like experiences that occur without external stimuli. Disorganized thinking is typically inferred from the individual speech that may switch from one topic to another as derailment or loose associations. Answers to questions may be unrelated or tangential. It is important to remember that speech may be so severely disorganized that it is nearly incomprehensible. There can be disorganized or abnormal motor behavior, which may manifest in a variety of ways, including childlike silliness to unpredictable agitation. Clients and patients with this disorder may have difficulty performing activities of daily living. This may include catatonic behavior, which is a marked decrease in reactivity to the environment and will be discussed towards the end. Negative symptoms account for a substantial portion of the morbidity associated with schizophrenia, but are less prominent in other psychotic disorders. 2 negative symptoms that are prominent in schizophrenia include diminished emotional expression and avolition. So diminished emotional expression includes a reduction in the expression of emotions, namely in the face, with eye contact, intonation of speech, and movements of the hands, head, and face. Avolition is a decrease in motivated, self-initiated, purposeful activity, including, and this may be displayed as the individual sitting for long periods of time and showing little to no interest in participation in any kind of work or any kind of social activities. Schizotypal, delusional, and brief psychotic disorders. So schizotypal personality disorder was discussed in the PowerPoint presentation under personality disorder, so I'm not going to go over that again here. With delusional disorder, this includes several possible subtypes. There's erotomanic, which means that someone is in love with them. There's grandiose, having a great but unrecognized talent, skill, or insight. There's jealous, extreme belief in partner's infidelity. Persecutory, which is they're being conspired against, they're cheated, they're being spied on, followed, poisoned, or drugged. Maligned, harassed, or some other way that they are being obstructed from pursuing their goals. There's somatic, which involves bodily functions or sensations. There's mixed, which is a variety of thematic subtypes. And then there's unspecified. So these delusions cannot be clearly defined, determined, or described. With brief psychotic disorder, diagnostic features of this is a disturbance that involves a sudden onset of at least one of the following positive psychotic symptoms: delusions, hallucinations, disorganized speech, or grossly abnormal psychomotor behavior. It can be sudden onset is defined as the change from a non-psychotic state to a clearly psychotic state within about a 2-week period of time. Some associated features. So individuals with this disorder typically experience emotional turmoil or overwhelming confusion. They may rapidly shift from one intense affect to another. The disturbance may be brief, however, the level of impairment may be very severe. There appears to be an increased risk of suicidal behavior, particularly during the acute episodes. Development and course. This disorder may appear in adolescence or early adulthood, and onset can occur across the lifespan, with the average age of onset being in the mid-30s. By very definition, the time frame is typically 1 month. Risk and prognostic factors. Temperamentally, diagnosis of other mental health conditions such as schizotypal personality disorder, borderline personality disorder, or traits in the realm of psychosis may predispose the individual to developing this disorder. With culture and functionality, it is important to remember that symptoms of brief psychotic disorder must include those that are not culturally sanctioned. For example, religious ceremonies, an individual may report hearing voices, but this symptom generally does not persist and is not perceived as abnormal. Clinically, it is important to gather information about certain displays related to symptoms of the disorder, and also to take those cultural aspects into consideration. Schizophreniform, schizophrenia, and schizoaffective. So with schizophreniform disorder, this is characterized as they're identical to those of schizophrenia. However, it is distinguished by its difference in duration, with the total duration of the illness being at least 1 month, but less than 6 months. So associated features, there are no laboratory or psychometric tests for this disorder. However, there are multiple brain regions where neuroimaging, neuropathological, and neurophysiological research has indicated abnormalities, but nothing is diagnostic. Developmental and course. So about 1/3 of individuals with an initial diagnosis of schizophreniform disorder recover within about 6 months, with the majority of the remaining 2/3 of individuals eventually receiving a diagnosis of schizophrenia or schizoaffective disorder. Functionality, there are functional consequences similar to schizophreniform disorder and schizophrenia, with individuals experiencing dysfunction in several areas of daily life, such as work or school, interpersonal relationships, and self-care. With schizophrenia, individuals with this disorder may display inappropriate affect, such as laughing in the absence of an appropriate stimuli, dysphoric mood that can take the form of depression, anxiety, or anger, and disturb sleep patterns. There may also be a lack of interest in eating or even a refusal to eat. Depersonalization, derealization, and somatic concerns may occur and sometimes reach delusional proportions. Anxiety and phobias are also common, along with cognitive deficits. Deficits that may include decreased declarative memory, working memory, language function, and other executive functions, as well as slow processing speed. Development and course. Psychotic features of schizophrenia typically emerge between the late teens and mid-30s. Onset prior to adolescence is rare. The peak age of onset for a first psychotic episode is in the early to mid-20s for male identifying patients, and in the late 20s for female identifying patients. The onset may be abrupt or insidious, but the majority of individuals manifest a slow, gradual development, a variety of the clinical significant signs and symptoms. The predictors of course and outcome are largely unexplained and may not be reliable or reliably predicted. Most individuals with schizophrenia require formal or informal daily living support, and many remain chronically ill. However, this condition is manageable with medication. Schizophrenia and prognostic factors. Environmentally, it has been shown that season of birth may be linked to higher incidences of schizophrenia, including late winter and early spring. There's a higher diagnosis of schizophrenia and related disorders in children growing up in urban environments and for some minority ethnic groups. Genetically, most individuals with this diagnosis have no family history of psychosis. There may be a link to birth and pregnancy complications associated with hypoxia and greater paternal age. Culture and gender. Clinicians must be careful when diagnosing schizophrenia, particularly when the individual and clinician do not share the same cultural and socioeconomic background. What may be considered delusional in one culture may be commonly held in another. It's important to remember that some cultures' visual and auditory hallucinations, along with a religious content, are a normal part of religious experiences. It is also important to recognize there are cultural differences in style and expression of emotion, eye contact, and body language. There are distinguishing features in the clinical expression of schizophrenia between genders, mostly related to symptom expression. According to the DSM, approximately 5 to 6% of individuals with schizophrenia complete suicide, with around 20% attempting suicide on one or more occasions. Suicidal behavior or ideations may be in response to command hallucinations to harm oneself or others. Functionality. There is an associated significance of social and occupational dysfunction. Schizophrenia often interferes with educational progress and maintaining employment, especially when cognitive skills are a major factor. Rates of substance use disorder are really high in schizophrenia, as is also the use of tobacco. There can be comorbid anxiety disorder, obsessive compulsive disorder, and panic disorder. It is reported that life expectancy is reduced in individuals with schizophrenia because of associated medical conditions such as weight gain, diabetes, metabolic syndrome, and cardiovascular and pulmonary disease, and some of these are due to medications. This may be, again, due to poor engagement in health maintenance behaviors. Again, medications, lifestyle, cigarette smoking, and diet. Schizoaffective disorder. So diagnostic features of schizoaffective disorder is based on the assessment of an uninterrupted period of illness during which the individual continues to display active or residual symptoms of psychotic illness. Some diagnostic criteria associated with schizoaffective disorder include delusions or hallucinations for 2 or more weeks in the absence of a major mood episode such as depression or mania. Associated features, there's occupational functioning is frequently impaired, but this is not a defining criteria. Restricted social contact and difficulties with self-care are associated with schizoaffective disorder, but negative symptoms may be less severe and less persistent than those seen in patients diagnosed with schizophrenia. Poor insight is a common deficit in schizoaffective disorder, but may be less severe and pervasive than those diagnosed with schizophrenia. Individuals with this disorder may be at an increased risk for developing episodes of major depressive disorder or bipolar disorder if mood symptoms continue following the remission. There may be a high level of alcohol or other substance-related disorders. There are no tests or biological measures that can assist in making a diagnosis of schizoaffective disorder. Development and course. Typical age of onset is early adulthood, although it can occur anywhere from adolescence to later in life. A typical pattern includes an individual having a pronounced auditory hallucination or delusions for 2 months before the onset of a prominent major depressive episode. The psychotic symptoms and the full major depressive episode are present for 3 months, with the individual recovering completely from the major depressive episode, but the psychotic symptoms persist often more than a month before they disappear. Depressive and manic symptoms can occur before the onset of psychosis, during acute psychotic episodes, during residual periods, and after cessation of psychosis. So, culture. The same cultural considerations must be taken into account in any one of these disorders that are categorized under schizophreniform spectrum and other psychotic disorders. It is important that a clinician take careful consideration into any differences of cultural and economic background. It is imperative that you educate yourself about those differences, how they can affect diagnosis, as well as information that you're gleaning from any people that you are working with. With substance or medication-induced psychotic disorder or catatonia. So, substance or medication-induced psychotic disorder, the diagnostic features of substance of this disorder are prominent delusions and or hallucinations that are judged to be due to the physiologic effect of the substance or the medication. This disorder can be distinguished from primary psychotic disorders by considering the onset, course, and other factors. This disorder may arise during or soon after exposure to a medication or after substance intoxication or withdrawal, but can persist for weeks, whereas primary psychotic disorder may precede the onset of substance or medication use and may occur during times of sustained abstinence. Some associated features: psychotic disorder can occur in association with intoxication with the following classes of substance: alcohol, cannabis, hallucinogens, including phencyclidine and related substances, inhalants, sedatives, hypnotics, and anxiolytics, stimulants, including cocaine and other known or unknown substances. Withdrawal from the following classes of substances may also cause psychotic disorder: alcohol, sedative, hypnotics, and anxiolytics. Medications reported to evoke psychotic symptoms include things like anesthetics and analgesics, anticholinergic agents, anticonvulsants, antihistamines, antihypertensive, and cardiovascular medications, antimicrobial medications, anti-Parkinsonian medications, chemotherapy drugs, corticosteroids, gastrointestinal medications, muscle relaxants, non-steroidal anti-inflammatory medications, and other over-the-counter medications like pseudoephedrine, antidepressant medications, and disulfiram. Toxins that are reported to induce psychotic symptoms include anticholinesterase, organophosphates, insecticides, sarin and other nerve gases, carbon monoxide, carbon dioxide, and volatile substances such as fuel or paint. So when we finish up with catatonia here, this condition can occur in the context of several disorders, including neurodevelopmental, psychotic, bipolar, depressive disorders, and other medical conditions. Catatonia is defined by the presence of 3 or more of 12 psychomotor features in the diagnostic criteria. The essential feature of catatonia is a marked psychomotor disturbance that may involve decreased motor activity, decreased engagement during interview or physical examination, or excessive and peculiar motor activity. A clinical presentation can be puzzling, as the disturbance may range from marked unresponsiveness to marked agitation. Decreased engagement may be severe or moderate. Motor behavior may be complex or simple and may include echolalia or echopraxia, and some individuals may go back and forth between decreased and increased motor activity. During severe stages of catatonia, individuals may need careful supervision to avoid self-harm or harming others. There are also high risks of malnutrition, exhaustion, hyperpyrexia, and self-inflicted injuries.